Welcome to the Deep Dive. Today we are plunging into a topic that's far more common and potentially serious than many of us realize. Blood clots in the veins.
Yeah, we're specifically looking at venous thromboembolism, or VTE.
Right, VTE. That big term covers both deep vein thrombosis,
Yeah.
DVT, and also superficial thrombophlebitis, STP.
And the material we've reviewed makes it starkly clear why this matters. VTE is a significant public health issue affecting, well, hundreds of thousands in the U.S. annually. We're talking potentially up to 600,000 people each year.
That's huge.
Yeah.
And while superficial clots, the STP, are often painful and, more common, maybe treatable with simpler things.
Right.
It's the deep ones, the DVTs, that carry the major risk. One of the most alarming facts from the sources is the connection to pulmonary embolism, PE, where a piece of the clot breaks off, travels to the lungs. The CDC estimates, and this is staggering, 30,000 to 60,000 deaths annually just from PE linked to DVT.
It really underscores why understanding this is so vital.
Exactly. So our mission in this deep dive is to take you through the sources you shared, pull out the most crucial insights.
Yeah, help you grasp what these clots are, why they even form, who is really vulnerable.
And they're diagnosed, and crucially, what we can actually do about them.
Think of this as your shortcut to being well-informed on VTE, basically.
Okay, let's unpack this. Maybe start with the plumbing. A quick look at our venous system.
Good idea.
Think of it as the network bringing blood back to your heart. You've got the deep veins, kind of like the major highways running through your muscles, often right alongside arteries.
Below the fascia, yeah. And then the superficial veins, like the smaller roads just under the skin surface.
Got it.
And connecting these are perforating veins, like little side streets, linking the superficial system to the deep one.
Okay.
What's key here, especially in your legs, is that these veins have valves, like little one-way doors.
Ah, right. To keep the blood moving up.
Exactly. Essential for pushing blood upward against gravity, stopping it from just pooling down there. More valves the further down you go.
So, if that's the normal flow, what happens when things go wrong? How does a clot actually form?
Well, it's often triggered by some kind of disruption or injury inside the vein wall.
Okay.
This sends out signals that kick off a complex process, your body's clotting system. Platelets rush in, a mesh of fibrin forms, and bam, you have a thrombus, a clot.
So the body tries to fix the injury.
Right. And normally the body also has ways to dissolve these clots, but sometimes the system gets out of balance and the clot grows too large or just doesn't break down like it should.
And this is where that classic concept comes in, right? The Virchow Triad.
Precisely. It's like the three main pillars supporting clot formation, especially for DVT. It really highlights the key risk factors.
So what are they?
First, there's trauma to the vein wall itself. This could be obvious, from a direct injury, but it can also happen internally from things like surgery or certain medications being infused.
Oh, like with an IV?
Exactly. Or even just repetitive motion or external pressure can irritate the vein lining.
Okay, that's one. What's next?
Second, and this is a big one, slow or stagnant blood flow, stasis. If blood isn't moving briskly through the veins, it's much more likely to clot.
Like a slow-moving river versus a fast stream. Makes sense.
Perfect analogy. And third, a change in the blood itself that makes it more prone to clotting, what we call a hypercoagulable state.
Hypercoagulable.
This can be something you're born with inherited or something you acquire because of other medical conditions or maybe medications you're taking.
So putting that triad together, the trauma, the slow flow, the clot-prone blood who is actually vulnerable, what kinds of people or situations have these factors really playing out?
The sources give us a lot of detail here, and the key insight, I think, is that VTE risk isn't just about, major critical illness. It's often a stacking of seemingly common factors.
Stacking up, right?
Age is the most consistent risk factor. Your risk significantly increases as you get older, say between 20 and 80.
Why is that? Just getting older?
Well, it's likely a mix of things. Maybe decreased mobility, more underlying health issues accumulating, potential age-related changes making blood slightly more clot-prone, maybe even changes in the veins themselves.
Surgery feels like a really clear risk then, right? It combines the trauma and the being stuck in bed afterwards.
Absolutely. Surgery is a prime example of bringing multiple factors together. You've got potential direct trauma to vessels, the body's natural clotting response kicking into high gear because of the injury.
And then you're not moving.
and the mandatory immobilization afterwards, major stasis. The sources really highlight hip and knee replacements and hip fracture surgery as having particularly high risks, especially if no preventative measures are taken.
And that risk doesn't just stop when you leave the hospital door, does it?
That's a critical point. It continues after you leave if you're still not very mobile at home.
Hormones also came up significantly in the sources, which might be surprising to some people.
They definitely do. The role of estrogen is really emphasized. Oral contraceptives, particularly the combined ones with estrogen and progestin, can increase your risk anywhere from 2 to 8 times.
Wow, that's quite a range.
It is. And interestingly, patches might carry even higher risk than pills. Hormone replacement therapy, HRT, carries a comparable risk even with lower estrogen doses than OCs.
So even though the overall risk for, say, a young, healthy woman on birth control might be low.
The absolute risk is still relatively low for most fertile women, yes. But the risk is highest when you first start these medications, maybe in the first year. And combining them with other risk factors like surgery or smoking or maybe an unknown inherited issue that can significantly raise your chances.
And pregnancy is another time of increased risk.
Yes, pregnancy increases VTE risk about 3 to 6-fold. It's a whole combination of things again. Hormonal changes, especially high estrogen, physical pressure on the big veins in the pelvis as the uterus grows, causing stasis.
Makes sense.
Changes in the blood's clotting factors to prepare for delivery, and potential trauma during delivery itself, especially with a C-section, which carries a higher risk than vaginal delivery.
Are there factors that make pregnancy risk even higher?
Yes. Things like being older than 35 during pregnancy, being less mobile for any reason, obesity, or having had a DVT before definitely add to the risk.
Cancer is sadly another major risk factor mentioned prominently.
It is. Cancer patients have a much higher incidence of VTE. It's multifactorial. Tumors themselves can actually secrete substances that promote clotting.
Really?
Yeah. Plus, cancer patients often undergo surgery. They might be less mobile. Chemotherapy itself can increase risk. They might have central lines put in. The body's natural clot-busting system might also be less effective.
The sources mentioned cancer accounts for a big chunk of unexpected VTEs.
About 20% of VTEs found incidentally, yeah. Certain cancers carry higher risk, like pancreas, brain, ovary, lymphoma, while others like breast or prostate might be lower risk. But the key is that any active cancer significantly elevates the chance of clotting.
And it increases the risk of it happening again, too.
Yes, the risk of recurrence is definitely higher in cancer patients.
Okay, beyond these really big ones, age, surgery, hormones, cancer, what are some other common situations that contribute to that Virchow's Triad?
Well, prolonged immobility is a classic. Even something like being on bed rest for more than, say, 72 hours significantly slows blood flow because your calf muscles aren't doing that pumping action.
Right, the calf pump.
Heart conditions like congestive heart failure or irregular heart rhythms like AFib also lead to sluggish blood flow, promoting stasis. Severe dehydration or serious infections like sepsis can make your blood more prone to clotting that hypercoagulable state again.
And even simple medical procedures.
Yeah, things like venipuncture, getting blood drawn, or having IVs or central catheters inserted can cause local vein irritation, inflammation, and trauma. There's even a risk of infection in the clot called suppurative phlebitis.
And having had a VTE before is a big one.
Oh, absolutely. That's a very strong predictor of having another one. Other factors include significant obesity, and interestingly, varicose veins are listed as the most frequent risk factor for superficial clots, SVT.
What about genetics? Things you're born with?
Yes, definitely. Some people inherit conditions that make their blood clot more easily. Common examples are things like factor V Leiden mutation or deficiencies in natural anticoagulant proteins like protein C or protein S.
Okay. And what about travel? We always hear about economy class syndrome.
The sources note that while this gets a lot of attention, the actual risk often comes down to the duration of immobility combined with any other underlying risk factors you might already have.
So sitting for hours is the main issue.
Exactly. Sitting for many hours in a cramped seat definitely exacerbates stasis, but it's usually not the only factor at play if a clot develops. It often tips the balance if other risks are present.
This is where that case study you mentioned, Miss K, the 22-year-old woman after knee reconstruction, really brings it all together, doesn't it?
It's a perfect illustration. Think about her situation through the lens of the Virchow Triad. She had significant trauma to her knee from the injury and the surgery. Plus, they likely used a tourniquet during the operation. That's major trauma and stasis right there.
Okay.
Then, enforced immobilization afterwards because of the knee reconstruction, more stasis. Plus, she was on birth control pills, adding that hormonal hypercoagulability risk factor.
Right.
And even though she was young, the family history of blood clots mentioned in her case hints at the possibility of an underlying inherited factor too, maybe factor V Leiden or something similar.
So she wasn't just a young, generally healthy person having routine surgery. She had this stack of risks, the trauma, the stasis from surgery and immobility, the hormones.
Exactly. That combination put her squarely in the high-risk category, even at 22. Her case really highlights that it's often the combination that matters, not just one single thing.
Okay, so we understand how they form and who's particularly at risk.
Yeah.
What are the potential outcomes? Why do we care so much about finding and treating these clots?
Well, let's start with superficial clots, the STP. For those, it's usually localized symptoms, pain, tenderness along the vein, redness, swelling. You might even feel a hard cord under the skin.
Sounds unpleasant, but maybe not dangerous.
Usually, yes. But the key thing the sources point out, and this is important, is that even these seemingly minor superficial clots can sometimes be associated with a more serious DVT hiding in the deed system. Maybe up to 20% of STP cases have an occult DVT.
Wow, okay, so superficial isn't always just superficial.
Right. And rarely, superficial clots can get infected septic thrombophlebitis, which can be quite serious, even life-threatening. Or they can appear in multiple places and seem to move around, just called migratory thrombophlebitis, and that can sometimes be a sign of an underlying issue like cancer or a hidden clotting disorder.
Okay. Switching gears to deep vein thrombosis, DVT. The potential outcomes there are much more severe, right?
Definitely. The most immediate life-threatening risk we already mentioned is pulmonary embolism, that clot breaking loose and traveling to the lungs. That's the big emergency.
But even if you don't get a PE, a DVT can cause long-term problems.
Absolutely. And this is a major focus in the sources, the risk of developing post-thrombotic syndrome, or PTS.
PTS, tell us more about that.
The sources indicate that a really significant percentage of DVT patients, potentially 20 to 50%, so up to half, develop PTS. This is basically chronic damage to the vein walls and especially the valves inside the vein caused by the clot and the inflammation.
So the vein just doesn't work right afterwards.
Exactly. It leads to persistent swelling in the leg, chronic pain, a feeling of heaviness, and sometimes quite severe skin changes, discoloration, hardening of the skin. The sources even describe a classic appearance called lipodermatosclerosis.
Leukodermosclerosis?
Yeah, where the lower leg gets hard, brownish, and tapers down near the ankle, kind of like an inverted champagne bottle shape. And in severe cases, it can lead to venous ulcers, sores on the skin that are notoriously difficult to heal.
That sounds like it would really impact someone's life.
Oh, significantly. It affects mobility, ability to work, overall quality of life. It's a major long-term consequence.
And there were some extremely severe, though maybe less common, acute complications mentioned too.
Yes, things like phlegmasia albidolens, where the leg becomes very swollen, pale, and cool, often seen in pregnancy, and phlegmasia cerulea dolens, which is even worse. Massive swelling, the leg turns blue or purple due to lack of blood flow, intense pain, and it can rapidly lead to gangrene.
Wow.
These are true medical emergencies, often associated with extensive clots, maybe linked to advanced cancers. They really highlight the potential severity of DVT if it obstructs major outflow.
And all of this, the PE risk, the PTS, the treatments must have a real economic cost too, not just a personal one.
Absolutely. The sources mention the high economic burden associated with VTE, both the initial treatment and managing the long-term complications like PTS. It highlights why prevention and effective treatment are so crucial, not just for individual health, but from a societal perspective as well.
So given how serious this can be, how do doctors actually figure out if you have a DVT? The sources were really clear. You can't just rely on symptoms.
That's a critical takeaway. Clinical signs alone, like swelling, pain, redness, warmth, are simply not reliable for diagnosing DVT. Symptoms can overlap with so many other conditions, like a muscle strain or cellulitis, and maybe half of DVTs don't cause noticeable symptoms at all. They're silent until maybe a PE happens.
And that Hohmann's sign we learned about, pain when you flex the foot.
Mentioned specifically in the sources as being particularly unreliable. Don't hang your hat on that one.
Okay, so if symptoms aren't reliable, you need imaging to actually see what's going on inside the leg. What's the standard approach?
The first line of defense, the go-to test, is typically a venous duplex ultrasound.
Ultrasound, okay.
It's non-invasive. uses sound waves to create images of the veins, allows the technician to actually see if there's a clot inside, and also assess how blood is flowing through the vein or if it's blocked. It's highly effective, very sensitive and specific, especially for clots in the larger veins above the knee, the proximal veins.
Are other scans ever used, like CTs or MRIs?
Yes, sometimes a CT scan, specifically a CT venogram, might be needed, particularly if a clot is suspected higher up in the pelvic or abdominal veins, where ultrasound might be less clear. Venography, which involves injecting contrast dye directly into the veins and taking x-rays, used to be the gold standard.
Used to be.
Yeah, it's highly accurate, but it's invasive, can have complications like reactions to the dye or even causing clots itself. It's expensive. And frankly, ultrasound is so good and readily available now that venography is much less commonly used for initial diagnosis.
What about blood tests? Do they play a role?
Basic blood tests are usually done before starting treatment, things like a complete blood count, CBC, checking clotting times like PTT and PTINR, and kidney function, creatinine. This gives a baseline.
And any specific tests for clots?
A D-dimer test might be used. D-dimer is a substance released when blood clots break down. So if it's elevated, it suggests there's active clotting happening somewhere in the body.
So a high D-dimer means you have a DVT.
Not necessarily. Other things can raise D-dimer too, like inflammation, infection, recent surgery, pregnancy, cancer. But a negative D-dimer in someone considered low risk for DVT based on clinical factors can be quite useful to help rule out a clot without needing an ultrasound. It's more helpful for ruling out than ruling in.
Okay. And sometimes more specialized tests.
Yes. If there's a strong suspicion for an underlying inherited clotting disorder, especially in younger patients with unprovoked clots or a strong family history, special coagulation studies might be ordered to look for things like factor V Leiden or protein CS deficiency, but these are usually done later, not in the initial emergency workup.
Thinking back to Ms. K's case again, she had the symptoms, the pain and swelling, and she clearly had multiple risk factors. Why wasn't that enough to just start treatment? Why the ultrasound?
Precisely because, as the source emphasizes repeatedly, clinical signs are unreliable. Despite her clear symptoms and her obvious risk profile stacking up, you absolutely need objective evidence to confirm a DVT before committing someone to months of anticoagulant therapy, which carries its own risks.
Right, you need proof.
Exactly. So the venous duplex ultrasound was the right next step, the standard of care. And in her case, it confirmed the clot was there, extending through several key veins in her leg. It just validates the whole diagnostic approach. Clinical suspicion needs to be followed by definitive diagnostic testing.
Okay, we spent a lot of time understanding the problem, the risks, outcomes, diagnosis. Now, the crucial part, what can actually be done about it, both preventing it in the first place and treating it if it happens?
Prevention is absolutely key, especially in situations where we know the risk is high. For most people out in the community, the basics apply. Staying active, getting up and moving around regularly, flexing your feet and ankles if you're sitting for long periods.
Like on that long flight we talked about.
Exactly. Managing other health conditions, staying hydrated. If you have a known personal or family history of clotting, that's definitely something to discuss with your doctor. Maybe even consider special coagulation studies depending on the situation.
What about when you're in the hospital, especially around the time of surgery? That seems like a peak risk time.
It is. And prevention is standard practice there. Early mobilization is routine care. Getting patients up and walking as soon as it's safe after surgery is probably the single most important non-drug measure. It gets that calf pump working and prevents stasis.
But sometimes people can't get up right away.
True. So if early mobilization isn't enough, or if someone is at particularly high risk, mechanical methods are used. Graduated compression stockings can help, though they're often seen as an adjunct. More effective are intermittent pneumatic compression, IPC devices.
Those things that inflate around your legs.
Yeah, they rhythmically squeeze the calves, mimicking the muscle pump action to improve blood flow. They're especially useful when anticoagulant medications might be too risky, like right after certain surgeries.
You mentioned IVC filters earlier, too.
Yes, inferior vena cava filters. These are tiny cage-like devices placed in the main vein, returning blood from the lower body. They're designed to catch large clots traveling up from the legs before they can reach the lungs. But they are generally reserved as a last resort, usually only if someone has a DVT or PE, and absolutely cannot take blood thinners due to active bleeding or very high bleeding risk. They don't treat the clot in the leg, they just prevent PE.
And medications are used for prevention, too, prophylaxis.
Yes, for many moderate to high-risk patients, especially hospitalized or post-surgical ones, pharmacologic prophylaxis is standard. This usually involves low doses of injectable anticoagulants.
Like heparin.
Traditionally, low-dose unfractionated heparin, UFH, was common, given subcutaneously a few times a day. More often now, low molecular weight heparin, LMWH, like enoxaparin, Lovenox, is used.
Why the shift to LMWH?
It's generally more predictable in its effect, can often be given just once a day, and usually doesn't require routine blood monitoring for preventative doses. It's just more convenient and potentially safer in some ways. There are also some newer oral anticoagulants like rivaroxaban or dabigatran that are approved for VTE prevention after specific surgeries like hip or knee replacement. Warfarin might also be used prophylactically in some very high-risk outpatient situations.
Okay, so that's prevention. Let's talk about treating an established clot. How is superficial thrombophlebitis, STP, typically managed?
For uncomplicated STP, the kind most people get, treatment is usually focused on symptom relief. Applying moist heat to the area, elevating the affected limb, and using nonsteroidal anti-inflammatory drugs, NSAIDs, like ibuprofen can help with pain and inflammation.
What if it's caused by an IV line?
If it's related to an IV catheter, removing the line is the essential first step. If there's any suspicion of infection like increasing redness, pus, fever, then antibiotics are definitely needed. The sources mention vancomycin often being used initially because of the risk of MRSA.
And if the STP is in varicose veins?
For STP specifically in varicose veins, the approach is similar. Symptomatic relief, encouraging activity, maybe compression stockings. If it keeps recurring, sometimes surgical removal of the affected varicose vein, phlebectomy, might be considered.
All right, now for the main event. Treating a confirmed deep vein thrombosis, DVT. The core treatment is anticoagulants, blood thinners.
Yes, and the most important insight here, something really stressed in the sources, is understanding what anticoagulants do and, importantly, what they don't do.
Okay, what's the key difference?
They don't usually actively dissolve the existing clot. Your body's own natural clot-dissolving system, fibrinolysis, does that gradually over weeks or months. The main job of anticoagulants is to stop the current clot from getting any bigger, and critically, to prevent new clots from forming or pieces of the existing clot from breaking off and traveling to your lungs, causing that dangerous PE.
So it's about prevention of worsening and embolization, not clot busting.
Exactly. Stabilization and prevention.
What are the main types of anticoagulant medications used for DVT treatment?
There are several classes, broadly injectable and oral. The traditional injectable is unfractionated heparin, UFH. It works quickly, often given as an IV drip initially in the hospital. Its main downside is that it requires very careful monitoring with blood tests, specifically the APTT, to ensure the dose is therapeutic but not dangerously high. It also has a short half-life, which can be an advantage if bleeding occurs or surgery is needed.
And it has a reversal agent?
Yes, protamine sulfate can reverse its effects. Heparin is also considered safe during pregnancy. A major potential complication, besides bleeding, is heparin-induced thrombocytopenia, or HIT.
HIT, that sounds serious.
It is. It's an immune reaction where heparin paradoxically causes new clot formation and a drop in platelet count. It's a non-hemorrhagic but very serious complication that needs careful monitoring of platelet counts when using heparin.
Okay, what about the other injectable, LMWH?
Low molecular weight heparin, like enoxaparin, Lovenox, or dalteparin, Fragmin. These are given as subcutaneous injections, usually once or twice a day. They have a much more predictable anticoagulant effect than UFH.
So less monitoring needed?
Generally, yes. Routine blood monitoring usually isn't required, except perhaps in specific situations like severe kidney disease, obesity, or pregnancy. They also have a lower risk of causing HIT and potentially less risk of osteoporosis with long-term use compared to UFH.
Can LMWH be reversed?
Protamine sulfate can partially reverse LMWH, but not as completely as with UFH. Bleeding is still the main risk.
And then there are the oral options, starting with the classic one.
Right. Warfarin, brand name Coumadin. It's been around for decades. It works by interfering with vitamin K, which is needed to make several key clotting factors. It's taken as a pill, usually once a day.
But it needs careful management, right?
Very careful. Its big challenge is that the dose required varies hugely between people and can be affected by many things. So it requires regular blood tests measuring the INR, International Normalized Ratio, to make sure the blood is thinned just enough, usually aiming for an INR between 2 and 3, but not too much.
Why does the INR need checking so often?
Because warfarin interacts with tons of other medications, supplements, herbal remedies, and importantly, with the amount of vitamin K in your diet. Foods rich in vitamin K, like leafy green vegetables, can counteract warfarin's effect.
So you have to avoid greens.
Not necessarily avoid, but be consistent. The key is maintaining a steady intake of vitamin K so your INR stays stable. Sudden changes in diet, starting new medications, even getting sick can throw the INR off. It also takes several days to reach its full effect, so it's usually started while the patient is still on heparin or LMWH, overlapping for about 5 days until the INR is therapeutic.
Any other major issues with warfarin?
The main risk, like all anticoagulants, is bleeding. Its effects can be reversed with vitamin K or specific clotting factor concentrates if needed. A major contraindication is pregnancy, as it can harm the developing fetus. There's also a rare but serious side effect called warfarin-induced skin necrosis.
Okay, so warfarin is effective, but requires a lot of monitoring and management. What about the newer oral options, the NOACs or DOACs?
Yes, the novel oral anticoagulants or direct oral anticoagulants. These are generally much simpler to use. There are 2 main classes mentioned, factor XI inhibitors and direct thrombin inhibitors.
Factor XI inhibitors.
Examples include rivaroxaben, Arelto, apixaben, Eliquis, and edoxaben, Savaysa. There's also an injectable factor XI inhibitor, fondaparinux, Awixtra, which is sometimes used initially or if someone has HIT. These oral agents are usually taken as fixed doses once or twice a day.
And the big advantage?
The biggest advantage is that they generally do not require routine blood monitoring like warfarin's INR checks. They have fewer known food interactions, although drug interactions can still occur.
What about downsides or things to watch for?
They are primarily cleared by the kidneys, so they need dose adjustments or may be contraindicated in severe kidney disease. They also need caution with liver disease. And for a long time, a major concern was the lack of specific reversal agents if major bleeding occurred, although antidotes are now available for some. Fondaparinux, the injectable one, is noted as safe for patients who develop HIT.
Okay, and the other class, direct thrombin inhibitors.
The main oral one is dabigatran, Pradaxa. Similar advantages to the factor XI inhibitor's fixed dose, no routine monitoring. It also has an available reversal agent, adarucizumab. Like the XI inhibitors, it requires caution with kidney function and potential drug interactions. There are also IV direct thrombin inhibitors like argatroban or bivalirudin, which are primarily used in the hospital setting, specifically for patients who have developed HIT.
So lots of options now, it seems good. How long do people typically need to stay on these anticoagulants after a DVT?
The duration really depends on the circumstances of the clot. The courses suggest that for a first DVT that was clearly provoked by a temporary risk factor like surgery, trauma, immobilization, maybe starting OC's treatment is often for a finite period, typically 3 to 6 months.
And if it wasn't provoked, or keeps happening?
If the DVT was unprovoked, meaning there wasn't a clear temporary trigger, or if someone has had recurrent VTE events, or has an ongoing significant risk factor like active cancer or a major inherited clotting disorder, thrombophilia, then lifelong anticoagulation is often recommended, provided the individual's risk of bleeding isn't considered prohibitively high. It's always a balance between the risk of another clot versus the risk of bleeding from the medication.
Beyond the medication itself, what else is important for recovery from a DVT?
Supportive measures are really crucial. Graduated compression stockings are often recommended, usually starting after anticoagulation is stable. They help manage swelling and pain, and importantly, they are thought to reduce the risk or severity of developing that long-term post-thrombotic syndrome.
How long do you wear those?
Often for up to 2 years or longer if symptoms persist. Elevating the affected leg frequently, especially when sitting or lying down, also helps with swelling. And progressive ambulation, getting up and walking, is encouraged as tolerated. It helps improve circulation.
Earlier, you said anticoagulants don't dissolve the clot, but sometimes you hear about treatments that do. What's that about?
That's thrombolysis, or clot-busting therapy. It uses powerful medications like streptokinase, urokinase, or tissue plasminogen activator, TPA, that are designed to actively break down the fibrin mesh of the clot.
Why isn't that used for everyone then? Sounds good.
Because it comes with a significantly higher risk of serious bleeding, including potentially fatal bleeding inside the brain, intracerebral hemorrhage, so it's typically reserved for very specific, severe cases.
Like which ones?
Usually for patients with very extensive DVT involving the major veins in the thigh and pelvis, iliofemoral DVT, especially if it's causing severe symptoms or threatening the limb, like in those phlegmasia conditions we mentioned. The potential benefit is faster symptom relief and maybe a better chance of preserving vein valve function long term, possibly reducing the risk or severity of PTS.
But it's a big trade-off with the bleeding risk?
A very big trade-off. There are strict criteria for who is eligible and numerous contraindications, like recent major surgery, stroke, active bleeding, or uncontrolled high blood pressure. It's a major decision. Thrombolysis can sometimes be delivered directly into the clot via a catheter, which might reduce the systemic bleeding risk compared to giving it intravenously.
And occasionally, actual procedures or surgery might be needed.
Yes, sometimes. Interventional radiologists or vascular surgeons might perform DVT thrombectomy, physically removing the clot, often using catheter-based devices. This is usually best done early, sometimes in combination with catheter-directed thrombolysis.
And those IVC filters again.
Right. Vena cava filter placement is an interventional procedure, primarily to prevent PE when anticoagulation isn't an option or has failed. And for specific situations, like recurrent superficial thrombophlebitis related to varicose veins that doesn't respond to other measures, surgical treatments like vein stripping or phlebectomy might be considered.
We focused a lot on the legs, which makes sense as it's most common. But the sources mentioned clots can happen in the arms too. Upper extremity DVT.
They absolutely can. Upper extremity DVT is less common than in the legs, but it happens. The precipitating factors can be a bit different.
Like what?
Frequently, it's related to having central venous catheters, those lines put into large veins in the neck or chest for long-term IV access, like for chemotherapy or nutrition, that irritate the vein wall.
Right.
But it can also happen spontaneously, sometimes after strenuous muscular effort involving the arms, particularly in athletes. That's called Paget-Schroeder syndrome or effort thrombosis. It can also be caused by compression of the veins near the shoulder by anatomical structures, thoracic outlet syndrome, or sometimes by underlying tumors pressing on the veins.
And the symptoms are similar. Arm swelling.
Yes. Key signs include swelling of the arm, pain, maybe a bluish discoloration, and visible veins across the shoulder or chest. Potential complications include PTS in the arm, PE, though maybe less common than from leg DVTs, and even superior vena cava syndrome if the clot extends centrally.
How's it diagnosed?
Diagnosis is typically confirmed with duplex ultrasound of the arm veins, similar to the leg. Sometimes venography or CT-MRI might be needed. Treatment also usually involves anticoagulation.
You mentioned superior vena cava, SVC syndrome. That sounds serious.
It is. SVC syndrome is often considered a medical emergency. It happens when the superior vena cava, the large vein that brings all the blood from your head, neck, arms, and upper chest back to the heart, gets blocked or compressed.
What causes that?
Most often it's related to cancer in the chest, like lung cancer, especially bronchogenic, lymphoma, or metastatic tumors pressing on or invading the SVC. Sometimes a large clot, perhaps originating from an arm DVT or a central line, can obstruct it too.
And the signs are dramatic.
Very dramatic. Because the blood can't return easily, you get swelling of the face, neck, and both arms. You might see prominent dilated veins across the chest wall as blood tries to find alternative routes back. People can develop shortness of breath, cough, headache, dizziness, vision changes, even confusion. Symptoms are often worse when lying down flat.
How is it managed?
Diagnosis usually involves imaging, like a CT scan. Treatment focuses on relieving the obstruction and treating the underlying cause. Immediate measures might include elevating the head of the bed, giving oxygen, sometimes diuretics or steroids to reduce swelling. If a thrombus is involved, anticoagulation is started. Often, radiation therapy or chemotherapy is needed urgently if it's caused by a tumor. Sometimes stents are placed to open up the SVC.
Okay, that's a huge amount of information on the medical side. Let's bring it back to the listener. How does all this empower you listening now in your own health journey? The sources really hammered home the importance of patient education.
Absolutely. That came through loud and clear. The key takeaway for you is this. Be aware of your personal risk factors. Think about it. Have you had recent surgery or major injury? Are you on hormonal medication like birth control or HRT? Is there a family history of clots? Are you dealing with an ongoing condition like cancer or heart failure? Have you been immobile for a while? Knowing your potential risk stack is really the first step to being vigilant.
And knowing the signs and symptoms is crucial too, right? Especially the urgent ones.
Yes. Be aware of those local symptoms we discussed: unexplained pain, swelling, redness, or warmth, particularly if it's just in one leg or arm. But most importantly, you need to recognize the urgent warning signs of a possible pulmonary embolism or even a stroke, which can sometimes be related.
What are those critical signs again?
For PE, the big ones are sudden shortness of breath, sharp chest pain, especially when breathing in, a rapid heart rate, feeling lightheaded or faint, maybe unexplained anxiety or coughing up blood. For stroke symptoms, remember FAST. Facial drooping, arm weakness, speech difficulty. Time to call 911. Any sudden numbness or weakness, especially on one side, confusion, trouble seeing, severe headache.
And the message for those symptoms is?
Call 911 or your local emergency number immediately. Do not wait. Don't try to drive yourself. These are potentially life-threatening emergencies that's stressed very clearly in the material.
Okay. And if someone is diagnosed with VTE and prescribed blood thinners, understanding the medication is vital.
Absolutely critical. You need to know the name of your medication, the exact dose, how often to take it, and why you're taking it. Understand the potential side effects, especially bleeding and bruising. Know what signs of bleeding are minor versus major and when to seek medical attention like blood in urine or stool, nosebleeds that won't stop, coughing up blood, severe headache, or unusual bruising. Also watch for any new rash.
And for warfarin specifically.
If you're on warfarin, you must understand the INR goal, how often you need blood tests, and the critical importance of consistency with your vitamin K intake from diet. Get a list of potential drug interactions, including over-the-counter meds like aspirin or NSAIDs, which significantly increase bleeding risk when combined with anticoagulants and herbal supplements. Always tell any doctor, dentist, or pharmacist that you are taking warfarin or any other blood thinner.
What about managing injections if someone is on LNWH at home?
They need proper teaching on how to give subcutaneous injections, safely rotating sites, proper technique.
And carrying ID.
Yes. Always carry some form of identification stating you are on anticoagulant therapy. A wallet card, a medical alert bracelet. This is crucial in an emergency.
Home care and safety precautions are important too, especially on anticoagulants.
Definitely. If you're on blood thinners, you generally need to avoid contact sports or activities with a high risk of serious injury or falls. Be extra careful using knives or other sharp objects. Use an electric razor instead of a blade.
What about falls?
Preventing falls is key. Make sure your home environment is safe, good lighting, no loose rugs. If you do have a fall, especially if you hit your head, you need to seek medical attention right away, even if you feel okay initially because of the risk of internal bleeding.
And compression stockings.
If prescribed, wear them consistently as directed. Ensure they fit properly, they need to be measured correctly. Ill-fitting stockings won't help and could even cause problems.
What about activity? Just rest.
No, generally not. Regular walking is usually encouraged, as advised by your doctor. Avoid sitting or standing still for really long periods. Elevate your legs when resting. Avoid crossing your legs or wearing tight, constrictive clothing around your legs or waist. Maintain a healthy diet, and again, if on warfarin, keep that vitamin K intake consistent. Stay hydrated.
Let's use Ms. K one last time to illustrate how this patient education really comes together practically. After her DVT was diagnosed and she started treatment, what would her discharge education ideally cover based on everything we've learned from the sources?
Her education plan would need to be really comprehensive. First, it would reinforce her specific risk factors, making sure she understands the link between the surgery, the immobility, and crucially, discussing the risks of her birth control pills and exploring alternatives with her gynecologist.
Okay, risk factors covered.
Then, detailed teaching on her anticoagulant medication. Let's say she started on warfarin bridge from LMWH. She'd need to know her INR goal range, the schedule for her INR checks, the critical importance of dietary consistency regarding vitamin K, and a clear list of potential interactions, other meds, alcohol, smoking, supplements.
And how to manage the medication safely.
Exactly. How to recognize signs of minor versus major bleeding, what to do, and when to call her provider or go to the ER. She'd absolutely need to know those urgent symptoms of PE or stroke and to call 911 immediately if they occurred.
What about lifestyle stuff?
She'd get clear guidance on wearing her compression stockings correctly, the importance of elevating her leg when resting, how to gradually increase her activity level, especially walking, as her knee allows, and safety precautions while on anticoagulation, avoiding high-risk activities, fall prevention. They'd also likely assess her home situation. Does she have support? Can she manage her INR appointments and medication regimen? It's a whole package.
It's really clear that VTE, covering both DVT and STP, is a complex but incredibly important topic with potentially serious, long-lasting health implications.
It really is. But the overriding message that comes through from the sources, I think, is ultimately one of empowerment. With awareness of the risks, understanding your personal risk factors, knowing what symptoms should prompt medical attention, getting a proper and timely diagnosis, and then adhering carefully to the prescribed prevention and treatment plans.
Including all that crucial patient education.
Exactly. Including that education, you can significantly impact the outcomes and dramatically reduce the risk of those serious complications like PE and post-thrombotic syndrome. Patient knowledge and engagement truly are key here.
So building on that, here's a final thought for you, our listener, to ponder. Given the incredibly wide range of factors that can increase your risk for VTE, everything from major medical events like surgery or cancer, to things as seemingly common and unrelated as taking birth control pills, being pregnant, or even just sitting still for a long journey, how might thinking more broadly, maybe more proactively, about seemingly routine aspects of your own life or health history help you, perhaps someone you care about, identify a potential VTE risk that might otherwise go completely unnoticed?
It's a great question. Being proactive and informed really can make all the difference. If anything we've discussed today resonates with your situation or raises questions or concerns, the best next step always is to have a conversation with your healthcare provider.